Okay, in the interest of time, I'm going to kick off our webinar this morning. Kevin, can you hear me okay? Sound check?
Yes.
Perfect, I can hear you just fine as well. Okay, well, let's get this thing rolling. Good morning and welcome. Thank you for joining us for today's Fundamentals in Healthcare Law webinar focused on Medicare Basics. As many of you know, this is our 7th of 12 webinars in our Fundamentals of Healthcare Law series. Our next webinar is scheduled for Wednesday, April 20th from 8:30 to 9:30 a.m., and it will focus on Medicaid in Idaho. So please be sure to mark your calendars. You'll also get some information from us with registration details. My name is Jason Castor, and I'm the Chief Business Development Officer for Parsons, Behle, and Latimer, and I'd like to again welcome you to today's presentation. Thanks again for taking time out of your schedules to be with us this morning. Before I introduce our speaker, I'd like to cover just a couple of quick logistical items. First, today's webinar is being recorded, and you will be provided a link via email to the recording to share with your colleagues and teams that weren't able to join us this morning. This email will also include a copy of today's PowerPoint presentation. Second, we have allotted time at the end for Q&A, so please use the chat feature to submit your questions throughout this morning's discussion, and we'll do our best to address your questions at the end of today's presentation. And finally, it's important to note that today's presentation is considered a general source of information, and it is not intended and will not serve as a substitute for legal counsel on these issues. You should not act upon the information provided without consulting your legal counsel. Okay, with all of our housekeeping items aside, I'd now like to introduce our presenter. Kevin West is a shareholder in the firm's Boise office and is the chairperson of the firm's Health Law Department. He has extensive experience representing healthcare providers in a variety of matters, including audits, investigations, medical malpractice, and licensure board disciplinary matters. Kevin, thanks for joining us. Thanks for being with us this morning, and I'll now turn the time over to you to take us away.
All right. Thank you very much, Jason, and good morning. Welcome to everyone. You know, we do look at the registration list for these webinars, and I have noticed we have a very faithful core group of people who have stayed with us over the last 7 months, and thank you for that. And I hope you're finding this ongoing series beneficial. It's an ambitious thing for our firm to do 12 months worth of webinars, but I hope people are finding it very helpful and beneficial. So I'm going to go back just one, make a few comments. We're going to talk about Medicare Basics. The Medicare program is an exceedingly complicated and vast program. There's no way we can obviously go into great detail today, but I think we'll give you a good basic overview and working knowledge of the program. You know, just to give a little perspective, I suspect that most in our audience today cannot ever remember a time when the Medicare program did not exist. And even though it began in the year 1965, it just seems like it's always been there. And you know, it's really difficult to fathom our society without the Medicare program when you think about it. I mean, I wonder what did the elderly do before 1965 when they retired from the workforce? How did they handle their healthcare needs? You know, Medicare has just become such a key part of our society and our way of life in the United States. So the Medicare program began back in 1965 with a package of pretty revolutionary social welfare programs as part of the Lyndon Johnson administration, what they called the Great Society. And it came down with the Medicare Part A and Part B, as well as the Medicaid program. So this set of legislation was really absolutely revolutionary. And there on the screen, you see some of the key events in the history of the program. In 1997, a major thing happened where we had the beginning of a new type of coverage at that point called Medicare Plus Choice, and now it's known as Medicare Advantage. That was a big development. In 2003, the prescription drug coverage began with Medicare Part D. Of course, the Affordable Care Act, which some people refer to as Obamacare under the Obama administration, began in 2010 and made a great number of changes to both Medicare and Medicaid. And then in the past decade, a large series of reforms as to how providers are paid, kind of under the heading of this law called MACRA. So let's talk about some things. This is sort of a simplified org chart. We could have a chart with dozens of boxes, but this probably suffices. Health and Human Services at the federal level is a cabinet level department of the federal government. The agency Centers for Medicare and Medicaid Services, which we just call CMS, is an agency within HHS. And then beneath CMS is a large array of contractors, most notable being the Medicare Administrative Contractors, which I'm going to call MACs, which administer Medicare Part A and Part B. In the old days, when I started working in this area, we called them Medicare carriers when it came to Part B, and we called them fiscal intermediaries when it came to Part A. That's a long time ago. They've been consolidated now. We call them Medicare Administrative Contractors. We have the Medicare Advantage companies that administer Part C. We have prescription drug contractors. And then, of course, we have Medicaid agencies. So that's a very simplified org chart. We could do much more in this particular area, but that's good for now. So some key terminology that is important, and some of this terminology in my mind is very unfortunate, but in Medicare speak, a provider is an institutional healthcare provider, such as a hospital or a nursing home. A supplier is a physician, a surgery center, a DME supplier, dialysis provider. So most of us in the healthcare world, we just talk about healthcare providers generically, and that's usually sufficient. But when you start reading Medicare statutes and regulations and rules, you need to be very aware that this strange distinction exists between providers and suppliers, and you'll misunderstand or misapply some of the law unless you're recognizing this distinction. I would throw one other term in there, and that is the term beneficiary. And beneficiary is, of course, the person that is receiving services from a provider or a supplier. It's also helpful to understand a little bit about the Medicare system and the way it's administered. So there are these jurisdictions, which you can see in color, where the Part A and Part B of Medicare are administered by private government contractors. There are 7 of them, and these are the MACs that I referred to earlier. So for those of us here in Utah and Idaho, that the MAC is Noridian. And you know, these contractors, their employees are not government employees. They are private employees of these companies. Noridian is a private company. And so that was one of the great compromises when the Medicare program was handed down, is that it would be a government program, but it would be administered by private companies, such as the MACs that you see here around the country. It's also important to understand a very critical thing, and that is that CMS sets national policy for the Medicare program, for its coverages, its payment, and all of that. So there is a national policy set, but these individual MACs that you see on the map, they have the authority to determine local coverage policies. And those policies cannot conflict with national policy, but those local policies can provide very stringent requirements on how providers document things in their medical records and certain conditions to Medicare coverage. So providers who live in these various regions have to be very familiar with not only national Medicare policy, but also local policy handed down by their particular MAC. So probably one of the most important things to understand about the Medicare program as a whole. All right, when we talk about the world of Medicare, there are three key areas that need to be recognized. Those areas are eligibility, which has to do with who is covered. Secondly, benefits, which deals with the what is covered. And then we have payment, which is when and how much does Medicare pay for a particular service. So let's spend a few moments talking about these three areas, starting first with eligibility. It's easy to think that Medicare is just comprised of the elderly, but that would only be 85% true, as you can see from the chart. So most of the Medicare population, of course, are those who are 65 and older. You typically must be a U.S. citizen, but legal aliens are also allowed to participate under certain conditions where they have been admitted to the United States for permanent residence and they have resided here for at least 5 years. And then, of course, for everyone, you have to have enough credits to be eligible, meaning you have to have enough time in the workforce, which is not a rigorous amount of time, but enough time in the workforce so that you have had, the Medicare tax deductions from your paycheck to fund your participation. So those are the requirements that most Medicare participants meet. So what about the other 15%? And here we have a mix of people where the government determined that they were going to automatically be placed into the program, and it's really not even a choice at this point, but they are placed in the program. So those who have been on Social Security disability for more than 24 consecutive months are eligible for Medicare. People with Lou Gehrig's disease, ALS, and those that are receiving treatment for end-stage renal disease. In other words, they're receiving kidney dialysis and they've been in that status for more than 3 months. So that's the other 15% of Medicare. So important to realize it's not just the elderly, that's most of the participants, but it's not only them. All right. This graphic shows one of the reasons why our Medicare system is financially in some difficulty. As you see the phenomenal growth in the number of enrollees. As of last count in 2020, about almost 63 million enrollees. And current projections are that the Medicare program is supposedly going to go broke by the year 2026. Just about the time I'll be getting there, age-wise. So we know politically that is not going to be allowed to happen, but we have some bad demographic trends in our nation with a large baby boomer population moving into retirement, and we have a following population of younger people whose numbers are far less. We have low birth rates in our country. So, there are some reasons for concern. I'm sure politically this is not going to be allowed to happen, but as you can see from this graphic, this program is growing tremendously each year. So let's move now to a second area and talk about benefits. And here we get into what are called the Medicare Parts. And a part is simply a type of coverage, if you will. And we start off with Part A. which is sometimes referred to as hospital coverage. We're really talking about inpatient benefits. And for most folks, there is no premium for this coverage. There is a deductible and a copay if you have paid Medicare taxes for 10 years. So that is the fundamental Part A coverage. We then go into Part B, which for many years has just been referred to generally as medical insurance. And here we have physician services and outpatient services. So some of those services could be rendered in a hospital, but if they're rendered on an outpatient basis, then it falls under Part B. We have lab services, diagnostic services like radiology and imaging and pathology, those types of things. And we also have home health services. A change that has happened with Medicare Part B is that there used to be a very low universal monthly premium for everyone. Medicare has now become what is called means tested. In other words, the premium is now being scaled depending on income. And right now, the current range is at the low end, $135 per month, and at the high end, $460 per month. And it's a sliding scale depending on income. There is a deductible and 20% copay like there is with most private insurances. So that's Part A and B. Then we go to Part C. Part C is actually an alternative to Parts A and B. So you either choose to be in what's called traditional Medicare, where you have Parts A and B, or you go to an alternative, which is Part C, and this is what is now known as Medicare Advantage. Medicare Advantage plans are run by private insurance companies, and it's similar to, they are similar to MACs, only really they are farther outside the realm of the federal government. They still have to follow certain federal regulations, but these are truly private entity companies running Medicare Part C. Medicare Advantage is what is known as a capitated type of health plan. So capitation means that the government is paying a fixed amount per beneficiary to the Medicare Advantage plan. So instead of paying directly for services, fee for service, they are paying a fixed amount per beneficiary per month. And that fixed amount varies to some degree depending on the age of the person and the different diagnoses they have as they come into the program. So as you think about that, say the company is getting $500 a month for a particular person. If that person is healthy, the Medicare Advantage plan is going to make money on that $500. If the person is sick, they are potentially going to lose money. And the idea is that it's all going to average out to where this can be run at least some profit by the Medicare Advantage plan. So the other thing that's important to understand is that these plans must accept all enrollees who qualify. So they can't necessarily game the system by only taking healthy people, and they very much assume the risk. The government is basically transferring the risk of the cost of care to these private companies. As of the most recent count, there were about 22 million people enrolled in Medicare Advantage plans. So that's about a third of all Medicare beneficiaries. So these plans have been very popular since they were initiated. There are upsides and downsides to Medicare Advantage plans that we'll talk about in just a moment. Then we finally go to Medicare Part D, which is the new prescription drug coverage that began during the Bush administration in 2003. This coverage is optional. You don't have to have it, even though you may have other Medicare coverage. There is the monthly premium and annual deductible, except for the poor. and this is also administered by private insurance companies. So as we talked earlier, Medicare does not cover everything. There are copays and deductibles, and many people buy these so-called supplemental or Medigap policies that are designed to cover services not covered by Medicare and to cover copays and deductibles. And these policies have become very popular. They used to be, in the early days, very unregulated, and there were a lot of abuses. Today there's federal regulation of these policies, which are very popular, and many people purchase them. So some people think Medicare covers everything. That clearly is not the case. On screen, you see a very short list of some major things that are not covered by Medicare, such as cosmetic surgery. If you're a healthcare provider and you render services to immediate relatives, that's not going to be covered. Dental services are a major area, which is another reason people buy these supplemental policies. And then routine foot care conditions are generally not covered, with some exceptions. All right, so let's go to a third area of discussion, and that is the area of payment, having to do with how much and when payment is made to healthcare providers. And here we really have to divide the world once again into Part A and Part B. So for Part A services, these are primarily hospital services. Payment is based on a very complex formula that has the title diagnosis related group. That's the formula. And very simplistically, this comes down to the patient's diagnosis, age, the complications they have, the comorbidities that they have. And basically, the hospital receives an estimate of what historically and demographically services should cost to the typical person who meets various criteria. So it's not even based on actual amount. It is based on this particular estimate. Then we go to Part B with physician services. And again, we have an extremely complex formula that has been evolving very dramatically over the years. And in the old days, there was really only 3 criteria in this formula. That had to do with the amount of work involved in the service, the malpractice insurance costs, and then practice overhead, which was adjusted according to where you happen to work. That was, for many years, the criteria. In recent years, however, the reforms have added many other factors. In the early days, there were factors having to do with your use of technology. This was referred to as meaningful use. And payment was adjusted up or down depending on whether you were using technology and providing certain information to the government. More recently, quality measures have been added to physician compensation formula. And those quality measures will adjust the amount of payment up or down from the base amount. And if you were doing everything you're asked by the government, all these quality measures, all the use of technology, your base amount of Medicare compensation can go up or down as much as 9%, which is quite significant, obviously. One last few comments on Medicare Advantage plans. As stated earlier, these are administered by private insurance companies. They are required to provide all of the basic Medicare benefits, but they are allowed to go above and beyond and provide additional benefits, which is the reason these plans have become very popular. So that's the upside of Medicare Advantage. The downside is that their provider networks tend to be much narrower and more restrictive. So many people going into these plans find that the doctors they've all physicians and others who participate in these plans, sometimes they have different rights and obligations, different policies they must follow. So there are ups and downs to these Part C Medicare Advantage plans. All right, well, that is a very whirlwind tour of some fundamentals of the Medicare program in terms of how the program operates, payment, and those types of things. We're going to transition now to a new area, and this is really what I would call the enforcement side of Medicare. This is the part that keeps healthcare providers and their attorneys up at night worrying about different things. And the reality here is what the government gives, the government can also take away. And many years ago, when I was in a Medicare hearing with an administrative law judge, we sat across the table and she looked at us, and she was something of a curmudgeon, this judge. And she said, when you deal with the government as a Medicare provider, you must turn square corners. I always remembered that 20 years later, that comment of you must turn square corners. In other words, you must be very meticulous on compliance, or there are going to be potentially problems. So it goes without saying that healthcare providers in general are highly regulated, and those who participate in the Medicare program are especially regulated, and they need to accept the burdens of this type of regulation. And of course, audits, investigations have become very common in recent years as the government seeks to enforce the various mandates. So some years ago, I was asked to speak in a conference regarding the various types of government audits and investigations. And in an effort to show the breadth and daunting scope of these different investigations, I tried to craft a chart, and I realize that's somewhat small, but I was trying to show both at the state and federal level all of the different types of audits that could happen to a healthcare provider. I'll just kind of zoom in on the top half of that chart, which are government audits. And really today we're mainly concerned with the federal upper half, and really concerned with the box where you see coding and billing, and over on the side you see various contractors. We've talked about MACs, RAC audits, there are CERT audits, there are ZPIC audits, and this chart is actually outdated because I would have to add some additional boxes in more recent years. And then we have these Medicare suspension and revocation matters that we'll talk about in a few moments. But you can see just from this simplified chart a variety of audits that can happen. And the government employs an array of different contractors, each of them doing very specialized audits. And these different contractors approach providers at different times, and providers need to be very savvy as they are approached and as they react to what is being requested of them in these particular audits. Let me also make a comment here. You know, we can't delve in necessarily to the details of how audits and investigations occur. That would take an entire seminar in and of itself. But the biggest protection healthcare providers have is in the quality of their medical record documentation. If that documentation is well done and meets coverage guidelines, that provider is always going to come out well in an audit. But there's been a development in the past 10 years that has caused problems, and that is the development of electronic health records, which are now almost universal. I still come across some providers who are still doing paper. They're a very tiny minority, but they still exist. Most folks are using electronic health records. And this has been both a blessing and a curse. The blessing has been that the amount of information that can be easily assembled and placed into the medical record and the ability to communicate across platforms has certainly been a benefit. But the downside of these electronic records, which I will tell you I look at virtually every day of my medical or my legal practice, the downside is the quality and the content has gotten worse, in my opinion. It is too easy to use drop-down menus and to use autofill and to use carry forward features of these softwares to populate a record that is full of information, but at the same time has almost no meaning. And sometimes when you document everything and say everything, you're sometimes saying very little at the same time. It's easy to become very lazy in using these records. It's actually more time consuming to make a good medical record with the software as opposed to just manually. There is a higher risk of what Medicare auditors call cloning, which is basically creating identical records from one visit to the next without really customizing the record. And then we've had the advent of a new class of staff called medical scribes, that the doctors are now basically dictating their chart notes to a person sitting in the room who is scribing or writing out the record. And there are certainly rules on how that is to be done and documented in the medical record. So that's just sort of an aside on the whole topic of being audited and being investigated. It all comes down to the doctor's medical record. And it often is not a question of the healthcare provider, whether they're a good provider or providing quality of care. That's usually not the issue in most audits and investigations. And I have doctors say to me all the time, I provided great care, my patients were happy, I helped them tremendously, and that's usually not the issue in an audit. The issue is usually, did you document the services appropriately? Did you meet the coverage criteria? That is usually what is happening. I could mention a few war stories. I've just got these little catchphrases here of things that have happened. This one about "I feel your pain." I represent a lot of podiatrists, and one of the coverage criteria for certain foot conditions is that the person have pain in their feet, particularly in their toes. And I represented a podiatrist whose attitude was, if a patient was coming to me, that meant they have pain. Otherwise, they wouldn't cover to me. And that podiatrist would always, on every visit of every patient, document that they had pain. Well, some investigator out there somehow caught onto that, and the government sent some retired FBI agents wearing recording devices to this doctor's office. And during the course of their visits, they made a point to say very specifically that they were not feeling pain. But the doctor's record later reflected that they had pain. And that particular doctor ended up having a criminal conviction and a great deal of trouble in his life following that. Big Brother is watching. I have represented healthcare providers who have been under surveillance, both video surveillance, tracking devices placed on cars, all these things that you would never imagine happening in the healthcare world. represented a doctor who one morning was there in the office with his staff. They looked out the window, and in the bushes surrounding the office were agents with vests and guns who proceeded to enter the office and walked out with, as I say here, everything but the kitchen sink, taking computers, medical records, everything in his practice as they executed a search warrant. The 40-hour day. Medicare auditors are very good at gathering up on their computers all of the services rendered in a particular day by a provider. And they have found in certain circumstances, by just calculating the average time of a visit, that certain providers were working, 40-hour days. And because of the number of patients and visits that they purported to document during a particular time period. Another thing that's happened, particularly in the nursing home setting, with hundreds of patients, with many of them with similar names, billing companies will often start to enter a person's name on a computer system, and the autofill function on their system will enter a person's name, and it may be Mary Jones who was seen by the doctor, but the billing service bills another Mary Jones who happens to be deceased. And this is a frequent phenomenon. And the government's, Medicare's computers are very quick to pick up on situations where providers are billing for services to people who are deceased. And there are a tremendous number of audits and investigations happening over this. And then this last story is a provider that I represented on one occasion who thought, for the sake of efficiency, he would take a template with all of the physical and exam findings and photocopy that template and simply change the name as he went from one patient to the next, with no modification whatsoever of the medical record other than the name at the top. And obviously that was very quickly discovered by investigators. All right, so I'm going to move from that particular somewhat unhappy topic to another one, which in some ways could be even worse. And this is another area of enforcement where various punishments, sanctions happen. And these are generally under these categories of suspension, revocation, exclusion, and preclusion. And in this particular area, almost unlike any other, the punishments are very draconian. The federal government has great power. This is almost a strict liability situation where your otherwise good intent is not even considered. There are few protections like we see in the criminal and civil areas, and it's almost like a Dante's Inferno when it comes to government action and heavy-handed behavior. The government has an array of things they can do to healthcare providers in addition to just asking for money back. They can do many other things, and unfortunately, healthcare providers have limited due process rights in these situations. So the first of these is what is known as suspension. And this is a situation where claims are being submitted to the government, and the government basically is adjudicating those claims, but putting the money in a suspense account while the provider is being investigated. And basically these monies accumulate in that account, and at the end of the investigation, if the government determines that money should be returned, they can immediately go to that suspense account and offset those monies against any overpayment. Suspension typically lasts 6 months, but it can be extended. And obviously it's extremely damaging to the provider, their cash flow, is reduced or eliminated depending on how much Medicare work they do. And to impose a suspension requires only, quote unquote, credible evidence of fraud. And I will tell you that to a Medicare bureaucrat, credible evidence of fraud can mean virtually anything. And I truly found that almost any allegation to them amounts to credible evidence of fraud. And so this is a very broad, elastic area. And again, the government auditors just have tremendous discretion and power. Provider is allowed to submit a rebuttal, but really have no other appeal rights if that rebuttal is denied, which it typically is. All right, now we go from suspension to another sanction known as revocation. And a revocation is an action by Medicare in which a provider's participation status is revoked. And once again, providers do have appeal rights, but our experience is that judges are often giving great deference to CMS, and that this is almost a strict liability situation. What are the grounds for revocation? And there are quite a number of them, as you see on the screen there: criminal convictions, providing false information. I will note in particular a couple of these with on-site review showing the provider is not operational. Medicare contractors will actually physically go to a provider's location, and on occasion they find that there is no functioning or operating medical practice or operation at that physical location. Or they may find that the particular office has hours posted, but there is no one present at the particular place. And that can be grounds for revoking a provider's participation status, which is, again, a very severe penalty. So it's always very important as a provider that you post your business hours, and if you have posted those hours, that you have someone on site. Misuse of billing number is an amazingly common phenomenon out there, where one healthcare provider is billing for services under another healthcare provider's billing number. This is often done where I work mainly with physicians, where they bring a new physician in. That physician is not yet credentialed with Medicare, so they bill that physician's services under the existing doctor's number. That is a very serious breach that can result in revocation of the entire practice's billing privileges. And then, of course, abuse of billing privileges. We talked about this deceased beneficiary situation, or just a pattern or practice of submitting claims that do not meet requirements. These are areas of great concern as we work with healthcare providers. Some additional reasons out there, and I've had, as to number 7, situations where Medicare auditors showed up at a provider's practice and the provider refused to allow them to get copies of their medical records, very unwisely. And that in and of itself can be a grounds to terminate a provider's participation. Improper prescribing, failing to pay an overpayment or debt, and affiliating with those who are excluded or revoked from the Medicare program. The mere affiliation or hiring someone in your practice who is excluded or revoked from the Medicare program could be a grounds for you yourself to be revoked from the program. So serious, very problematic area. The next type of sanction is what is known as exclusion. And this is somewhat related to revocation, somewhat similar, only even a perhaps more severe penalty, where the provider, not only is their participation taken away, but they are legally excluded and barred from participating in any way in the Medicare program or from participating in any medical practice that participates and receives federal dollars. Exclusion can be of two types, permissive or mandatory exclusion. A very negative thing that happens if you are excluded is you are placed on the OIG excluded providers data bank, which is searchable by insurance companies, hospitals, medical malpractice companies, by really anyone can go search this data bank. The period of exclusion can be from 1 to 10 years. The grounds for mandatory exclusion from the program, you see there on the screen various types of criminal convictions related to the Medicare program, patient abuse, prescribing controlled substances. If you do any of these things or are convicted of them, you will be excluded from the Medicare program for a period of from 1 to 10 years. The permissive exclusion situations are situations where if you do these things, you will not automatically be excluded from the Medicare program, but oftentimes this will happen. So any conviction relating to fraud, obstructing an investigation, misdemeanor convictions related to controlled substances, and you see the others, license revocation, and again, this one of failing to grant access to CMS to see your medical records. There is a new type of sanction called preclusion, which is basically a sort of an adjunct, and providers who have been either excluded or revoked are placed on what is called a preclusion list by CMS. And that preclusion list is basically published to Medicare Advantage plans. So if you are on that list, you will not be able to participate in Medicare Advantage plans as well. So there truly is a domino effect of these sanctions. If you are revoked or excluded, it means you're going to be taken off of Medicare Advantage. You will also almost automatically be barred from participating in your state Medicaid plan. You potentially could be barred from participating in commercial insurance plans because they see your name on these lists or data banks, and you could potentially even be disciplined by a state licensure board. So having been through this painful process with many of my clients, it's just a horrible place to be, and definitely it can be a career-threatening event for healthcare providers. All right, so leaving the kind of the Dante's Inferno here to hopefully a lighter subject, but somewhat ironic topic of opting out of Medicare. And sometimes doctors who have heard all the things I've just been talking about say, I'm not sure I want to keep doing this in Medicare anymore, which is not a good reason to get out of the program. But there are some doctors for various reasons who decide that they no longer want to participate in the Medicare program. And it's not as easy as just saying, I want out. There is actually a legal process that must be followed. And we have helped a number of doctors do this. And the opting out process, as it's called, involves the provider sending a written notice to Medicare, which must meet certain requirements. And then if Medicare grants the request to opt out, the provider is given that status for a period of 2 years, and the provider can continually renew their opt-out status for successive 2-year periods after that. Now, importantly, providers who have opted out must give each of their Medicare patients notice in writing that they have opted out that Medicare cannot be billed for any part of their charges, either by the doctor or by the patient. And the doctor must actually sign a brief agreement known as a private contract with their patients, reflecting the fact that the doctor is no longer billing Medicare, that claims cannot be submitted to the Medicare program, and the patient must sign and agree that they are aware of that fact. So there are lots of ins and outs to operating a practice when you have opted out, and we will not go into that here, but it's important for providers to be aware that that is an option that is available to them. All right, well, we have covered quite a bit of ground today in learning about Medicare Basics. Jason, I'm going to turn to you and see if you've had any questions submitted, and we can address those if there are any.
Great, Kevin. Thank you very much, and a great presentation. Thanks for providing us with such an in-depth presentation today and helping us navigate the complexities. I haven't seen any questions come in through the chat feature yet. So, you know, before we conclude our presentation today, if there's any final questions that you have, please feel free to submit them via chat. I want to just remind all of you that our next webinar is scheduled for Wednesday, April 20th from 8:30 to 9:30, and this will focus on Medicaid in Idaho. And as I mentioned at the outset of today's presentation, you will receive more information and an invitation to attend this webinar on April 20th. You'll also receive a copy of today's recording via email, along with Kevin's PowerPoint presentation. Kevin and I would both like to extend another sincere thanks to all of you for being a part of our Fundamentals in Healthcare webinar series. We've appreciated your support of this, and we hope you find a lot of value in this. If you have other questions, please don't hesitate to submit those to us via email. Kevin and I will make sure that your questions get answered promptly. Kevin, before we wrap up today, any final thoughts on your end?
Well, I would just say, you know, the topic for next month goes really hand in hand with today's subject. Today was Medicare, which is a federal program. Medicaid, of course, is a state-run program which gets both federal and state dollars. So to get sort of the final half of the picture here, I think it would be good to hopefully have folks come back and hear the Medicaid side of the picture, as we'll do next month, and we'll look forward to hopefully seeing all of you again.
Great. Well, thanks again, Kevin, for preparing today's presentation, and I echo Kevin's comments. We look forward to seeing you next month, Wednesday, April 20th from 8:30 to 9:30. Check your inbox within the next 24 hours and you'll get more information. Thanks again for joining us, and have a great week.
Okay, thanks everyone.